your next specialty lecture. It's time to talk about labor and delivery. And instead of me jabbing about that for an hour, we are going to pass it over to our labor and delivery expert, Elizabeth. Elizabeth Dager is a women's health nurse practitioner who is a subject expert in maternity, labor, and delivery. Over to you, Elizabeth.
Okay, good morning, everyone. Thanks so much for joining me. I'm Elizabeth Geiger. I'm a women's health nurse practitioner, so I've spent a large part of my career doing this sort of stuff, maternity and labor and delivery. So I hope today I can share a little bit of what I learned with you and hopefully help you do better on your NCLEX as well. So, first of all, if you're talking labor and delivery, it's really important to know that there's a lot of different ways women can give birth. We always think, okay, this is going to be a hospital type of situation. They're going to go in and deliver the baby. But a lot of women choose not to deliver in hospital settings. So, I wanted to talk to you a little bit about those first of all. So, home deliveries are actually somewhat popular. And there are a lot of pros, but there are also a lot of cons that I always want my patients to consider if they're considering this option. What are the pros? Well, first of all, man, you have a lot of control over the birthing experience. You really get to dictate the setting, and the setting is familiar and safe feeling. You have a very high chance of a vaginal birth because that's pretty much the only option. It's vaginal, or you need to go to the hospital for a C section. There tend to be much fewer medical interventions because they're not available in the home setting. So for women who want a really natural birth, this might be appealing. There tends to be more support and individualized care. Typically, these deliveries are done by a midwife type of provider, and it would just be one on one the entire labor and delivery experience. So you tend not to get that as much in a hospital setting. You have providers coming in and out of the room. You have more unlimited skin to skin time with the baby. Typically, in a hospital setting, we're whisking that baby right off to do some initial assessments. If you're paying out of pocket, this is definitely a lot less expensive than a hospital birth. And definitely, if people have very specific religious or cultural beliefs, this is much easier to follow, typically in a home setting. Well, what are the cons? There are some pretty big cons I always want my patients to know about. First of all, the fact is, it is much less safe for both the mother and the baby, especially if there's underlying conditions or risk factors like placenta previa. That person should never try to, of course, deliver in the home setting because it's going to go wrong every time. That needs to be delivered via C section, and that's a condition we'll talk about later on. Also, conditions like preeclampsia and gestational diabetes. They increase a lot of major risks that can happen with labor. It's too much of a risk. They have to deliver really in a hospital setting. Insurance typically does not cover the cost of a home birth. So again, if you're paying out of pocket, it's cheaper. But if you want insurance to cover it, you more likely are going to want to do a hospital type setting. It is still possible, of course, if things go wrong, that both the mother and baby will need emergent transport to the hospital. If we discover, hey, wait, this baby isn't head down, they're breech, we're not going to be able to deliver them vaginally. We need emergent transport. And then finally, the honest truth, it is messy. The labor is very messy. And so I always warn people, prepare ahead of time, have plastic sheets and tarps, certainly have lots of towels. I have people who will use inflatable wading pools. That's very reasonable as well. So, one thing I do want to say about this was said by a very excellent provider I worked with for many years. He said, you know what? You really don't know if a pregnancy is truly low risk until the baby is safely delivered in that mother's arms. And that is so, so true. You can think, yeah, everything we've seen so far is low risk, but things in labor change rapidly. And when they change, you need to be able to fix them rapidly, and you can't always do that in the home setting. An in between option is going to be a birthing setting. So if you don't want to just flies more solo at the home setting, you want a little bit more support, you might try a birthing center. This also has a lot of nice pros. It's definitely a good option again for people who want a really unmedicated, low intervention birth. The rooms are really nice. They're built to feel like a home setting, not a hospital. And water births are often encouraged and allowed. So water births can be, wow, incredibly comforting and soothing when someone is laboring. That's not going to be allowed in a hospital, though. What's nice too is the center is going to deal with all the cleanup. That's a big bonus. And then finally, often they're going to deliver more personalized care again than you would get in a hospital because again, this is usually a midwife doing more of a one-on-one delivery. Well, there are also cons. So, first of all, women are generally sent home really quickly after this delivery, often within 6 hours if nothing's going wrong. And something you should know, and we're going to talk about this again later in the presentation, is postpartum hemorrhage. It's bad. It's an emergency when it happens. People can hemorrhage and die if it's not recognized quickly. And hemorrhages don't always happen within the first 6 hours. What are you going to do if people hemorrhage at home? It's a little risky in that regard. There are no medications available. So I have had people say, yeah, I'm going to go unmedicated all the way. And then they actually start laboring and realize, I wish I had some medications. Well, if they want that, they're going to have to take a trip to the hospital. There are no food or meals offered during the stay. It's truly just to center to deliver. So if you want anything extra, you need to bring it with you. They don't really have a lot of extra team members on staff like lactation consultants. So if there's any difficulty breastfeeding, and again, we'll talk about this later in the presentation. Breastfeeding is really hard for most women at first. You're not going to have that support in this type of center. And then again, if an emergency happens, the mother, the baby, both might need emergency transport to the hospital. And I always have to have the conversation with patients with both birthing centers and home births that, again, emergencies in obstetrics happen fast and need quick resolution. Many situations, if they happen by the time the woman or mother is transported to the hospital, they may not survive. There are many conditions that are not survivable if they're not caught quickly. So that's where the hospital setting comes in. And don't get me wrong, there are plenty of cons, but the pros are pretty important. So first of all, if there's an emergency situation, we have the equipment, we have the staff there to treat the mother and baby quickly. And again, sometimes you need rapid intervention. The mother and baby's health is going to be extremely closely monitored and attended to by a team of medical staff, multiple members watching different things. Meals, medications, even sanitary napkins and toiletries, all provided. Really the woman just needs to bring herself and any extra she wants for comfort. And then finally, they have a lot of specialists to help with skills like breastfeeding. That is so important, especially for new moms, but all of those other specialties, if referrals are needed, if someone is having signs of severe postpartum depression, well, we might want to call in psych. If someone has major pelvic floor issues after delivery, we might want to get a physical therapist involved as an example. So it's good to have those team members. What are the cons though? First of all, it's really, really hard to rest in a hospital. I always tell people, this isn't where you come to rest. This is where you come to have your health closely monitored. And for us to closely monitor your health, we're going to be in and out often. And, I always apologize ahead of time, but that's part of the deal. It is often a very sterile feeling environment, although more and more hospitals are trying to build delivery suites that feel like a home setting. They're pretty nice nowadays. It's definitely a little bit more difficult to follow a natural birthing plan because, the options are there. If you're in pain, it's easier to say, hey, go grab that if it's available, of course. Many holistic birthing options like water births, not an option. You can do a spa bath until your water breaks, but after the water breaks, you got to get out, which is kind of a bummer for those women who want to do that. It's important to have an advocate in a hospital setting. Definitely, it is a place where professionals and providers are often telling you as the patient what needs to happen, when it needs to happen. But often when you're in labor, you can't advocate for yourself. You're just focused on the labor. So having a partner or a doula or someone who can say, no, she actually wants this is important. If you're in a teaching hospital, we need to warn you, there could be a lot of students in the room. Sometimes a whole troop will go marching in the room to observe a birth. And I always tell patients it's your right to say no. They should ask ahead of time. If that makes you uncomfortable, say no, totally appropriate. And then finally, there is technically going to be an increased exposure or risk to infectious diseases. It's a hospital, although well-designed hospitals have infectious and non-infectious patients separated. Next, I want to talk about delivery methods because just like that picture we have in our mind about if you give birth, you have to be in a hospital, that's not always true. Not all deliveries are vaginal deliveries. Deliveries can happen in a lot of different ways. So I wanted to talk about those a little bit next. So first of all, there's the good old vaginal delivery. That's what we're most familiar with, and that's usually what happens. Of course, this is when the baby is born through the vaginal or birth canal. And most women are going to give birth naturally sometime between 39 and 41 weeks. That's why we give a date of 40 weeks. That's 50% of women will deliver by then. Are recommended to do this unless there's a medical reason for a C-section, because vaginal deliveries are much easier to recover from. They have much shorter hospital stays. There's fewer infections. The mother will recover faster, and the babies do much better. They have a lower risk of respiratory issues when born vaginally as well. More and more, I've had people come to me first-time pregnancy say, hey, I don't want to deal with any vaginal issues after birth. I just want to sign up for a C-section. Can we just do that? And I say, no, that's not really a good idea. It sounds like it would be an easier recovery, but it's far more risky, far longer, and far more painful. It's not a good option if we can help it. But sometimes the C-section is the only safe option to deliver the baby safely. And typically this is the delivery where the baby is being delivered by making a surgical incision first in the abdomen, cutting through the muscle layers, and then into the uterus. And while this is usually scheduled in advance, so, pretend if we know a baby is in the wrong position, they're breech, and we can't flip them, we're going to schedule them for a C-section. But, we do that. But this is actually also often done in response to an unforeseen complication during a vaginal delivery. So if we're doing a vaginal delivery and we have fetal heart rate monitoring on and it shows, this fetus is in distress, we might say, we got to deliver via C-section to speed this up because that baby isn't doing well. What are some other events, though, that might require a C-section? Well, if we have more than one baby, twins or triplets, sometimes we can deliver them vaginally, but often they're much more complex deliveries, and we will do those via C-section. Macrosomic babies, those big babies over 8 pounds, 13 ounces. Many times they are not able to fit safely in the vaginal canal, at least without, a high risk for trauma or dystocia getting stuck. So we will deliver sometimes them via C-section. Prior C-sections, especially if they have underlying uterine conditions. Malposition of the fetus, like fetal breech position where the butt is down first, or transverse position where the baby is sideways. And then placenta previa, we can never deliver that vaginally. That's a C-section delivery. Or fibroids or large uterine obstructions can require C-sections. And fibroids are actually a benign tumor that can grow in the muscle layer of the uterus. And many women have these. Over 50% of women will get these at some point in their lives. But for some women, they have huge fibroids that will block the birth canal, the opening of the uterus, and then we just have to do a C-section. But ultimately, no, this is a very major surgery. It requires much longer recovery times. Therefore, again, it should really only be done for medical reasons. And I should note too, in addition to increased risk of infection, increased pain, there's also increased risk of blood loss, increased risk of blood clots. It tends to make breastfeeding more challenging because there's a delay of when breastfeeding starts. So again, we don't want to choose to do this unless it's necessary. And know that as of 2020, 31.8% of pregnancies were delivered via C-section. So it's a pretty frequent delivery option. Last little bit about C-sections. There's two main incisions that are done. The right way to do it in the vast majority of situations is going to be the low transverse or horizontal incision. This is an incision that cuts across the lower, thinner part of the uterus, so right across that lower uterus. And these are the muscles that do not contract as strongly, as compared to the upper muscles in the uterus. So therefore, it makes it very unlikely that the uterus will rupture if they have a future delivery where they want to do a vaginal delivery after C-section. We'll talk about that more on the next slide. And therefore, this is usual practice for OBGYN since the 1970s, and the rupture risk is incredibly low. It's 0.5 to 0.9% if they do try that subsequent vaginal delivery. The vertical or classical incision is much higher risk. This is a vertical up and down incision that actually cuts down through the muscles of the uterus that contract the most strongly. Therefore, it's very likely that the uterus can rupture in a subsequent labor. And the risk is higher if the incision is higher in the uterus, because the muscles that contract the most are at the top of the uterus. It's rarely used now. We tend to only need to use this if there's really dense scar tissue in the uterus or adhesions. Also, for people with severely morbid obesity, it can be hard to do a low transverse incision. But the rupture risk is high. It's 4 to 9%. So anyone who's had a classical incision, they can't do a vaginal delivery after that. It's too risky. It's not safe. So let's talk a little bit about that vaginal delivery after C-section. This is also called VBAC, or vaginal birth after C-section. And historically, when a woman had a C-section, that was it. She could never try for a vaginal birth in the future. Now it's really nice. It's estimated that about 75% of women who try for a vaginal birth after C-section go on to have a successful vaginal delivery, but it is not for everyone. Some conditions preclude the possibility of a successful VBAC, that classical vertical incision or placenta previa. Remember, we can't do that. Not all hospitals will offer the option, as smaller hospitals tend to lack the staff and the resources to perform an emergency C-section if the VBAC attempt doesn't go well. And really, the most serious risk is for the uterine rupture. This is a really rare outcome, but this is very serious. It's serious harm to both mother and baby. Basically, what happens here is the uterus tears open, ruptures, and the fetus is expelled into the peritoneum of the mother, and there's just massive bleeding. Despite that, as long as it's recognized quickly, the infant survival rate is actually 85%. It's higher than you'd think, but most of these babies have long-term NICU stays and long-term health issues. So we want to avoid that, of course, and it's also a major recovery for the mother as well. I should mention too, providers, like when I see patients in the office who want to do a VBAC, I'll actually use what's called the VBAC calculator. And this helps me determine the risk, as the due date gets closer, as to whether or not they can try. If the calculator tells me their score, though, is less than a 50% success rate, we're going to say no, it's not worth it. And factors that we consider in the calculation are age, starting weight and weight gain, delivery history, that sort of thing. So it pretty accurately tells us whether we should try it or not. Next is another type of vaginal delivery. It's a vacuum delivery. So it's a vaginal delivery with the assistance of a vacuum. And this is considered a procedure where we're using this tool to assist with the vaginal childbirth. And basically, the provider uses this by applying the vacuum, which has a soft cup with a handle on it and a vacuum pump. You apply that to the newborn's head, you apply suction, and then you gently apply traction. You don't want to yank, that's not good, but gently apply traction to help guide the baby out of the birth canal. So it's a very helpful tool, but this is not without risk. If we are too forceful or not careful, this can lead to injuries including big hematomas, skull fractures, even brain damage, and cerebral palsy. So we got to be careful with that. Forceps delivery is also another type of procedure. It's also called an operative vaginal delivery. And this is basically where the provider applies the forceps, which can kind of look like a large salad tongs, to the baby's head, and it helps to gently guide the head through the canal. It's very important that the head, of course, is grasped gently. Injuries can include, again, bruising, facial palsies, again, even that brain damage or cerebral palsies. Most providers use the vacuum in most situations. However, if it's before 36 weeks gestation, forceps is actually recommended because it tends to do less injury to the skull, which is softer at that point. But after 36 weeks, it tends to be safer to use the vacuum. So that helps make that decision. But I get a lot of questions at this point. What are the main reasons we would even have to use these? Well, any reason you can't push is a very common reason. If the mother has a bad heart condition or really high blood pressure and she's not supposed to push a lot, we might help deliver the baby this way. If there's fetal heart rate concerns, if the baby's in the wrong position, like if the baby's head is in the wrong position, we might kind of guide it into the right position. But a really common reason we use this is actually maternal fatigue. Sometimes these women are pushing for an hour or two or three, and they're using every muscle in their body with every push. They just get exhausted and need help. So next, I want to talk about how can we tell if someone actually is in labor, because this is the role a nurse actually will often have in the office or in triage if they're in a hospital setting. If someone calls and said, hey, what's going on with this? We need to tell them when they're in labor. So first of all, it's important that you know what type of contractions indicate labor. These are true labor contractions, and what false labor contractions are. False labor, also known as Braxton Hicks, do not lead to true labor. So with true labor, we have contractions that are regular with the interval that gets a little shorter every time. But if you're using a stopwatch, they're pretty close to the same time every time. False labor is always very irregular. There's no rhyme or reason. They tend not to get closer together. For true labor, regardless of whether the mother is moving or resting or whatever she's doing, it's going to keep going. She can't do anything to make it stop. But with false labor, the contractions will stop if she does things to try to calm down her uterus. And I always tell women to try three things personally. I always say, okay, empty your bladder. A full bladder will certainly irritate your uterus. Drink a full glass of water and put your feet up and rest for 15 minutes. Usually false labor will stop when that is happening. If you do those three things, true labor will not stop. The intensity of contractions for true labor, they're just going to get worse and worse and worse. And I always tell people it's going to start out where you're like, okay, yeah, I can handle this, but give it a little time and you'll have to grab the wall that's near you and breathe through it. They become really, really intense over time. And then typically false labor, it's consistently weak and irregular. It doesn't get more intense. And then finally, true labor, for many women, they tend to start in the lower back and then move towards the front of the abdomen. Whereas false labor, the pain is just mostly in the front. It can also just mostly feel like a general tightening of the front of the uterus. But something I always like to tell people is the 511 rule. I always tell women this rule as they're getting into the mid 30s gestationally. I will say, okay, if you are matching up with the 511 rule, you need to go right to the hospital. This rule says if you're having a contraction every 5 minutes, the contraction lasts for a full minute, and that happens over the course of an hour. That's it. It's time to go to the hospital. You're truly in labor. The amniotic sac rupturing is also a very distinct sign of true labor. This can occur while a woman is actively in labor if her uterus is already contracting, or it can actually happen before the woman starts laboring or contracting. Typically, the rupture happens first and contractions will soon follow. Rarely, there's the big gush of fluid. That's what we see in movies, right? There's this huge puddle at the bottom of their feet. That happens maybe 10% of the time, but most of the time, there's this little pop as the sac ruptures, and there's this steady trickle of fluids. I always tell women if you were sitting on a toilet, you would hear a steady tinkle, tinkle, tinkle of the fluids. And if you were wearing a pad, you would have to change that pad probably more than once in an hour. Well, what do all these different acronyms stand for? They certainly expect you to know what they stand for on the NCLEX. So PROM stands for premature rupture of membranes. And what that means is the amniotic sac ruptured before the contractions began. So that could be at 39 weeks, that could be at 38 weeks, doesn't really matter what time it was happening. If the amniotic fluid ruptures first and then contractions happen, that's PROM. And just so you know, the best way to accurately tell if the amniotic sac is ruptured and contractions haven't started, because sometimes it's confusing. You're like, did they just pee their pants? Because sometimes women have a lot of urinary incontinence and frequency at this point, or are they actually in labor? Well, the best test to do is something called the nitrazine test. This is a test that uses a little pH strip piece of paper, and all we do is take that pH paper, we dip it in the amniotic fluid, the suspected amniotic fluid, and if it turns bright blue, if it has a very alkalotic or high pH, it's amniotic fluid. If it's green or yellow, if it has a much more acidic pH, it is not the amniotic fluid. What else? PPROM stands for preterm premature rupture of membranes. So what that means is the water breaks before the 37th week of pregnancy. So that specifically means the amniotic fluids ruptured before 37 weeks. That's premature. Remember, 37 weeks is what we consider to be term. That's when all of the fetal organs have developed. So if contractions are starting before 37 weeks, or if PPROM happens, if the water breaks before 37 weeks, we're not super happy about that. We'd rather they delivered a little bit later. We're also worried with both PROM and PPROM that, hey, if the bag of water stays open, if it stays ruptured for a really long time and the baby still isn't delivered, I got to start worrying about infection risk, because definitely that can cause a lot of issues that we'll talk about later, of course. And do you know that often the reason PPROM happens, the bag of waters rupturing before 37 weeks, a lot of times those women have an infection they didn't realize they had. Chlamydia is a common one, urinary tract infections. These can cause the bag of waters to rupture too early. Finally, we have AROM, or artificial rupture of membranes. That's also known as an amniotomy. And basically, that is when the provider will break the water. It's known as breaking of the water, actually. And the provider will intentionally rupture the membranes to induce labor, because usually, for most women, within several hours of the waters breaking, contractions will start. And this has been performed by obstetrical providers for hundreds of years. We've done this for many, many years. And we use something called an amni hook. It kind of looks like a crochet crochet hook. And all we do is we grab onto a little piece of the membranes and tug, and that ruptures the water. That's confused often with something else providers do as women are getting closer to their due date. Something else providers do is they strip the membranes. That's not breaking the bag of waters. When providers strip the membranes, they can do that during late pregnancy. That can maybe help speed up how soon labor happens. It leaves the bag of waters intact. The provider just sweeps their finger between the thin membrane of the amniotic sac and the uterus. It separates it from the wall. It's not comfortable to have that done, I'll tell you right now, but most women in late pregnancy are more uncomfortable being pregnant, and they're like, please do it. I'm ready to be delivered. What are some other signs? Well, bloody show is certainly a sign. I wouldn't say it's a 100% certain sign, but it's certainly something to be investigated. If a woman suddenly sees a small amount of blood, that can be seen when the cervix is making rapid dilation and effacement changes. But we always need to teach our patients as they're getting closer to their due date that a little bit of blood could be bloody show. Sudden large amounts of bleeding is never okay. Call 911. Get an ambulance. That could be previa or abruption. The mucus plug is definitely not a certain sign that you're going to go into labor, but it does tend to show up if women are going to have labor in the next couple of weeks typically. But women tend to lose this as they get close to labor because the cervix is thinning out and opening up, and that mucus plug that was in the cervix falls out. But the mucus plug can actually grow back and fall out again, so it's not certain. We just see it as we get closer. Back pain, especially just in the lower back, can be a pretty distinct sign of labor because for some women, especially women who have a uterus that's tilted backwards, called retroverted uterus, they really can't feel their contractions in the front. They feel it all in their back. So if I had a patient call and all they tell me is, I have really bad back pain that's kind of coming and going, but I can't get it to go away, I'd say, come in. We need to assess you for labor. And then finally, nausea and vomiting can be kind of a vague sign. As women are getting closer to labor, they have rapid hormonal changes that can cause some nausea and vomiting. But ultimately, it's really up to the provider to determine when a patient is likely in labor. The gold standard is to perform a cervical check, and that's going to tell us, if we have contractions that are leading to cervical dilation, that is the true definition of true labor. So, how do we assess for cervical changes? Well, first of all, we need to know how dilated the cervix is, how open it is, because once it's dilated to 10 centimeters, that's when the baby's going to be delivered pretty soon. And we actually assess this by inserting our fingers into the vagina, and we use our fingers to estimate how big in centimeters the dilation is. So typically, if I can just fit a little fingertip in just the end, that's about 1. A full finger is 2. 2 fingers is about 3 or more, and so on and so forth. You get an idea for what measurements equal what in centimeters. Same with effacement. With effacement, the cervix, as it's opening, it's also thinning out, and it's going to go from about the thickness of 2 centimeters to 0 centimeters. It thins out completely. And to measure this, we use our fingertip. And what I do is I say, if I insert my finger into the cervix and it goes to the second knuckle, it's 0% effaced. It's not thinned out at all. If it's to the first knuckle, it's 50% effaced. 50% of the effacement is done. And if it's at the fingertip, it's 100% effaced. We're about to go when it comes to labor. So let's go ahead and do a little practice question together. So basically, go ahead and put your answer in the question area when you're ready. And this says, a prima gravida patient at 39 weeks arrives at the hospital maternity triage unit reporting of a sudden gush of clear fluid from her vagina shortly before arrival. The maternity triage nurse suspects that the patient has experienced pre-labor rupture of membranes, or PROM. Which of the following is the most appropriate method for the nurse to use to confirm her suspicion? So go ahead and let me know what you think. Oh yeah, you guys are good. Very good, guys. Yeah. The answer is C. We want to use that pH paper, the nitrazine paper. We're just going to dip that right in the amniotic fluid, and that's going to tell us what we need to know. Do you know that a prima gravida patient means she's a first-time pregnant patient? A multi-gravida patient has had pregnancies before, but great job. Let's do another question. This says, which of the following are symptoms of true labor? And this is the select all that apply to make it a little bit harder. So go ahead and let me know what you think for this one. Okay, you guys are close. This is not an easy one. It's actually B and C. So why is it not A? Well, it's not A because if the contractions get better when you do something, it's false labor. True labor won't get better no matter what you do. It definitely is B. We're going to have contractions that come in regular intervals, getting slightly shorter with time. It also is C. Remember, low back pain for women who have a tilted uterus. For some women, that's the only symptom, but it's not D. Contractions are going to get worse and worse and worse and worse. And I always tell women, you'll think they can't get worse than this. They're going to get worse, until you're actively pushing. So be ready for that. So next, let's go ahead and talk about induction of labor. Why would you say to a woman, okay, you're not laboring on your own. We need to go ahead and induce you. Well, these are all the reasons I would do that. Well, a post-term pregnancy, a pregnancy that is past the full term due date of 40 weeks, that's not good. And if it's been more than 1 week, definitely more than 2 weeks. We never, at least in my office, would let women go past 42 weeks. We're going to induce her because what studies are consistently showing is that the placenta, as we get further past that 40-week date, starts to fail. It really is only built to last for about 40 weeks. The farther and farther you get past that time, the more and more it degrades, the less and less capable it is to transport nutrients and oxygen. So that's why women after 40 weeks, the risk of stillbirth starts to go up. And it's our job to prevent that. Prom is another important reason. Remember, if the amniotic fluid ruptures but contractions haven't begun, we need to know, hey, if this has been a while, we probably need to induce her because the longer the bags stay ruptured and open, the higher the likelihood is that we're going to get an infection. Growth restriction would be a very big reason we would go ahead and induce. This means that the fetus is no longer able to grow effectively in the womb and it needs to be delivered to be supported. And we see this often for situations like high blood pressure and preeclampsia. As that blood pressure gets sky high, the placenta no longer functions effectively. So that's often one of the reasons we're delivering those babies early. Macrosomia, also uncontrolled gestational diabetes, which will cause macrosomia, is another reason we might induce. If we, let's pretend, do an ultrasound at 35 weeks and we see, holy cow, this baby is already almost 9 pounds and they have 5 weeks to go, we might say, well, heck, if we're going to deliver them vaginally, we better send them in for an induction because if we wait another 5 weeks, the baby won't fit in the birth canal. We would have to do a C-section. So that's a big reason as well. A uterine infection might be a reason. Really advanced serious infections or unsafe environments for the fetus and, can be unsafe for the mother. We might deliver in that case. RH incompatibility would be a big reason. So remember, this is back in the other lecture, the maternity lecture, but if you have an RH negative mother and an RH positive baby and that baby's blood is exposed to the the mother could make those anti-Rh antibodies, which given enough time will attack and kill that baby. So if we do a lab and we see, oh no, those antibodies are already in the bloodstream, we would deliver the baby to get them out of that unsafe environment. Placental abruption would be a very big reason. If it's a minor, very small bleed, we can usually manage it and still deliver vaginally. If it's a serious bleed, definitely if it's a complete abruption, we have to do a C-section to save the baby and mother. And that's going to come up in a future slide as well. Medical conditions in the mother involving the heart, the lungs, the kidneys, severe obesity. These would all be reasons to induce as well. There are a lot of health conditions that can increase risk to the mother in terms of letting her stay pregnant for too long. Pregnancy puts a lot of strain on the heart and the kidneys and lungs, for instance, so we might deliver her early to reduce that strain. Also know that women with severe obesity, women with a lot of different health conditions like high blood pressure, high sugar, these will also increase the risk of stillbirth as the woman gets closer to 40 weeks. It even increases the risk before 40 weeks. So newer studies have shown that for some conditions like severe obesity, we want to induce these women at 39 weeks to greatly reduce that risk of stillbirth. It's a much safer option. If that woman has a history of precipitous or very, very fast labor, we would also definitely consider inducing because, I've had patients who barely made it to the hospital. I once had a patient who delivered in her car. If we know she delivers within minutes, we don't really want to wait till she goes into labor spontaneously. We want her safely in the hospital, so we might have it happen a little early. Finally, nowadays, women can actually choose to be induced just a little bit early. In my hospital system, you could deliver as early as 39 weeks. So if you had not delivered by then, you could schedule to be induced. And that was really nice for working women who needed to schedule work. Also for women who have other kids, they need to get childcare. So really nice option. But on the other hand, why would we decide to deliver someone, or why would someone go into preterm birth, and why would we want to stop that? Well, there's a lot of reason women go into labor too soon. And one of the biggest reasons is it's happened before. So, you get those questions on the NCLEX that say, what is the GT-PAL for this pregnancy history? And it's like, oh gosh, do we have to do this again? It actually is pretty important because at a glance, that will tell us, hey, that person had 3 preterm deliveries and they're currently pregnant. I better watch them pretty fast so it doesn't happen again. I better do interventions that will prevent that in the future. Pregnancy with multiples increases the risk of preterm delivery. Twins, triplets, very rarely do they make it to a full term due date. They usually are more frequently delivered in the early to mid 30s. A short time between pregnancies, less than 18 months, tends to cause an increased risk for preterm delivery as well. Conception through IVF is actually a really big risk because remember, with IVF, the embryo is not implanting naturally. We're artificially implanting the embryo after fertilizing it outside of the body. And it doesn't implant as well as it does naturally. Something is lost in that process. And because of that, they do have a higher risk for preterm delivery and some other issues as well. A history of problems with the uterus or cervix or placenta can cause this. A common reason would be cervical incompetence. Some women, the cervix does not stay shut the entire pregnancy. It starts to dilate and efface way too early. And we call that, again, cervical incompetence. And what we do is something called a cerclage, which is a fancy word for we stitch the cervix closed, actually. So if we have a history of a woman with incompetent cervix, usually in that first or second trimester, we stitch it closed and then we cut the stitch open as she gets closer to her due date. A history of cigarettes and illicit drugs will definitely increase the risk of preterm labor. And infections are a really major cause. That's why I put that in italics. Infections, remember, are a major reason the water breaks early. So we take infections in pregnancy very, very seriously. If someone says, hey, I think I have a UTI, I'm very aggressively going to evaluate and treat that because I don't want her to have preterm labor. Physical injury or trauma to the abdomen can cause this. Stressful life events can cause this. I've many times had patients tell me, yeah, my husband lost his job the other day and I went into labor. It definitely induce labor. And then finally, chronic conditions like diabetes or high blood pressure are risk factors as well. Well, next I want to talk a little bit about some OB pharmacology, and then we'll end on for OB pharmacology and we'll take a little break after that. But the reason I like to talk about that is these are the medications we use when we're inducing labor or when we're trying to stop preterm labor. So our tocolytics are what we use if someone is in preterm labor and we want to stop it. I always say these are the medications that pump the brakes. And these are terbutaline and magnesium sulfate, and we'll talk about those next. Oxytotics turn on the gas, they rev the engine. So oxytocin is what we use to turn on the gas and speed up contractions if we're trying to induce labor. So let's talk first about terbutaline. This is a selective beta 2 adrenergic agonist. And the mechanism of action is it's actually going to bind to beta 2 adrenergic receptors in the respiratory system to cause bronchodilation. And that's why terbutaline, first and foremost, is used as an inhaler for people who have bronchospasm. But it's also used in maternity because it works on the beta 2 receptors in the uterus, true. Also, the problem is you can't just use an inhaler to trigger the uterine receptors. You need to do a large oral dose. And unfortunately, that causes some pretty significant side effects. I always warn these women, hey, you're going to have CNS overstimulation. You're going to be jittery and shaky, anxious. You're going to have insomnia, maybe even headaches and nausea. People don't feel great on this. The other issue is vital signs all go up. It causes the heart rate and blood pressure to go up. It also causes blood glucose to go up. So these are all things we need to monitor. And of course, we need to continue to monitor contractions in the fetal heart rate. Magnesium sulfate is also a serious medication. This is an electrolyte that we use if someone is low in magnesium, of course, but we use this medication if we're trying to calm down something in the body. So we use it for preeclampsia. We'll talk about that in the future because it calms down seizure activity, but we use it in preterm labor because it calms down the uterine receptors that induce contractions and it slows or stops labor. But remember, you want to give this slowly and carefully because if people get hypermagnesemia, you can't arouse them. They're confused. They have no reflexes. So you want to give this really slowly. And typically people on a magnesium drip should get regular serial magnesium levels as well. Oxytocin is a hormone that induces labor, but also we'll talk about this also with postpartum hemorrhage in the future. It helps with postpartum hemorrhage because with postpartum hemorrhage there are vessels inside the uterus that are bleeding. If the uterus does its job after delivery and contracts down on those vessels, the bleeding will stop. If it doesn't, that's when you get a hemorrhage. So if people are hemorrhaging, we give this medicine so the contractions happen. But remember, if we're giving this in labor, closely monitor contractions, closely monitor the fetus, and warn the mother the contractions are going to get more intense and painful. This is really going to speed up that process. Something else you do want to know about oxytocin, this should always be given IV as a piggyback using an infusion pump. This is not a mild medication. You really need accurate control of how much and how fast is being infused. And ideally, if you're handling this with another infusion, this is nice. If we see signs of distress, we can easily stop the secondary infusion and run the other fluids really quickly if you have it as a secondary line. So that's always how you want to run this one. Prostaglandins are the last quick thing we're going to talk about. These ripen the cervix, and these include prostaglandin E1, misoprostol, and prostaglandin E2, dinoprostin. Just so you know, misoprostol tends to be most effective, is what studies are saying. So that's usually what I'm seeing in most hospital systems. But with misoprostol, it's an E1 analog. We use it for stomach ulcers as an aside, but we use it as induction of labor. It also is used for D&Cs and pregnancy termination. And basically, it causes the cervix to soften and the uterus to contract. So we use this if we're trying to maybe induce labor and the cervix won't ripen at all. We use this to help it dilate in the face. But remember, because this affects uterine contractions, we want to closely monitor those and the fetal heart rate response. No, this can be given sublingually or vaginally. Either way works. And use caution in women who have had a prior uterine surgery. This can very slightly increase the risk of uterine rupture. We do real quick want to warn these women. These tend to be mild, but some side effects or adverse, I would say side effects they can have are diarrhea, stomach cramps, and maybe a little nausea, but most people do fine. Dinoprostone is the prostaglandin E2 analog. That is going to be used for induction of labor. So we use it for elective termination of pregnancy as well. And it stimulates the muscles in the uterus to contract and also causes cervical dilation as well. But again, we need to closely monitor contractions in the fetal heart rate response. This is given either as a vaginal gel or suppository. And interestingly, this can very, very slightly increase the risk of amniotic fluid embolism, which is a very rare condition that causes amniotic fluid to enter the maternal bloodstream, which can cause a really severe reaction that can cause heart or lung failure. I've never seen it, really rare, but a very bad outcome. So finally, let's end with a question, and then I promise we'll take a nice 10-minute break. So this question says, a client presents to the obstetrics floor at 39 weeks gestation with irregular contractions. After you get the client situated in labor, delivery, and recovery room, you notice the client's healthcare provider enter the room to evaluate the client. Following the evaluation, the HCP exits the room, and shortly thereafter, you enter. During your discussion, the client states the HCP went to order oxytocin. In anticipation for that order, you understand the client's oxytocin will be administered via which route of administration? What was that route we want to use again? Good job, guys. Good. So you all got that, yes, we definitely want this as an IV. We're never going to give this IM or orally. That's not how it's given. But specifically, we want this as a secondary line because remember, if that fetus has adverse response to the medication, they start showing signs of distress, we want an option to turn off the secondary line while allowing other fluids to continue to run. Because remember, how do we treat fetal distress? We stop the Pitocin, that's the stressor. One of the things we do is we need to turn up IV fluid, so we want that to continue running. Next, I want to talk about pain control methods. We've talked about some of the other OB pharmacology, but pain control is a very important part of a nursing role that really helps make the entire experience so much better, so much of a better memory for these women. I have had women who have had really poor pain control issues, and I've even had women who have had PTSD from pain control issues in labor. So again, this is a very important nursing role. So, first of all, know that many women really want to avoid pharmacological options. They want to go natural if possible. And we should definitely support them if that's the option they want to use. That being said, I always tell these women, I think that's great. I'm going to tell you about all the ways we can help you achieve that. But if you happen to change your mind and decide you do need something for pain, that does not mean you're a failure or anything like that. It is very painful, and that's why that stuff exists. But first of all, hypnobirthing is a great method. This technique uses a very deep relaxation and basically self hypnosis to decrease anxiety, fear, and pain. This is not, however, something people can just figure out and do all of a sudden the day of their labor. They really would want to look into doing classes on this. Hydrotherapy is also really nice. Laboring in water has shown to not only increase relaxation and comfort, but it also decreases pain and anxiety. But again, the problem here is in the hospital setting, this is only allowed until the bag of water ruptures, and then they got to get out. Touch therapy potentially can be really helpful, but do remember people and women, of course, vary quite a bit on what amount of touch or type of touch is considered helpful versus a little bit uncomfortable. So we always want to ask, hey, would it be helpful if I held your hand through this next contraction, or would you want me to just rub your back a little bit? Always ask, but usually it is helpful. Movement is helpful. We want to encourage the patient, if she's not actively laboring or pushing, to consider getting up and moving around, maybe walking around. This really helps the uterus to work more efficiently during labor. And again, it's shown to decrease pain perception. Positioning can be helpful. If a woman is really uncomfortable in that normal position where she's on her back in the stirrups, we might want her to reposition. And a really helpful tool is something called a birthing ball. These are little, like, they kind of look like yoga balls basically, but they allow for back and forth swaying motions, front and back swaying motions as well. And this really allows the muscles in the pelvic floor to relax. And again, it really does relieve pain. And then finally, appropriate breathing helps. Really thoughtful, deep breathing both helps not only to provide distraction, but again, it helps with the pain. It relieves anxiety. It makes even potentially contractions more productive by bringing in more oxygen. And it potentially even can help reduce nausea. But again, people aren't just going to suddenly know how to do this. We should encourage them, to do a class where they learn breathing techniques. Something like Lamaze is a classic breathing technique. Nitrous oxide would be a nice, minimally invasive option. We could certainly encourage for someone who doesn't want to go for a major pharmacological option. This was first made popular in Europe and Australia, and is really becoming much more common throughout the US hospitals, as it's really minimally invasive. It really does also help manage labor pain. And this is really a tasteless and odorless gas that is mixed with oxygen through a mask. And the mother will hold on to the mask. She's not wearing it the whole time, but she basically decides when to take a breath. And typically, the most effective time to inhale is about 30 seconds before she's going to have a contraction. So, as the nurse, we should be watching the monitor and saying, hey, looks like you're going to have a contraction here in about the next 30 seconds to a minute. Go ahead and take another deep breath. This really works really quickly. Again, it works within a minute, and it reduces anxiety. It actually will create a feeling of well being. And it's nice too because it does not limit movement, it does not slow labor, and it does not cause any significant risk to the baby. So it's a great option. I will say rarely, some women are just a little sensitive to this and might feel a little dizzy or lightheaded. They may even have a little nausea or vomiting, but that's rare. And remember, this leaves your system super quickly. So if they have those, we just say, don't take another breath out of your mask. We'll try something else. Next, we have our systemic analgesics. These are going to lessen the pain without a loss of feeling or muscle movement. Typically, these medications are opioids, and we're going to give them in the IV. And the typical narcotics we're going to use are meperidine or Demerol, bupropion or Stadol, morphine or nalbutamine or Nubain. Do you know meperidine or Demerol? It's kind of going away in most US hospitals because, especially in the elderly, there were a lot of cases of toxicity, especially neurotoxicity. So you're not going to see that one much anymore, but the others are used a lot. And these typically really take the edge off. But honestly, the bulk of the pain is still going to be there. These do also cross the placenta, so limited use is better, as it can lead to respiratory depression in both the mother and the baby. However, if we're regulating use closely, APGAR scores are rarely affected. And then some hospitals will limit use to about an hour before the expected delivery. If you know that final hour they cut off use, and that really could potentially help lessen sedation in the newborn. This can also help with breathing in that first breastfeeding attempt as well. Next, we have our local anesthetics. This method is often used if an incision was made, like an epidural, or I'm sorry, an epidural and episiotomy, which is where we cut through the perineum or the tissue below the vaginal opening. We do that if the head is stuck and we're not making progress in labor. But more often, it's rare that we go right to the episiotomy. We usually let people tear a little bit on their own, which sounds like, ooh, that doesn't sound nice, but people tend to tear less than they would if we made a big cut on our own. So either way, if they have a tear or in a episiotomy was made, we have to repair that. And we would want to do a local anesthetic, something like lidocaine, to quickly numb that area. You wouldn't want to repair without lidocaine, but it does nothing to relieve the pain from contraction. So this is usually an added medication if they need a repair. Epidural was what my mind was on. This is one of the main methods that people use for pain control. And this is known as a regional anesthesia because it's a localized anesthesia that really blocks most of the pain. And basically, a lot of people think of an epidural and they think it's an injection into the spine. It is not. Sometimes an initial injection is made and then the catheter is placed, but the epidural itself is a catheter that is placed into the lower spine, and then that catheter slowly pumps pain medication to that area. And that then will stop pain signals from traveling to the spine and brain. And this method removes the vast majority, or sometimes almost all of the pain, really without slowing labor that much. The mother is awake, she's alert, and she should still be able to feel, hopefully, she should be able to feel pressure and contractions to know when to push. And I always tell people this has to be monitored very, very closely. You don't want it too high because then she's not going to feel the urge to push. You don't want it too low because then she's going to have pain. Another reason you don't want it too high is this can cause hypotension very, very quickly. So we need to monitor that as well. They don't always work. Some women report that like only one half of their body had pain control, or sometimes it didn't work at all. And then if we have time, we'll attempt again, but sometimes it just doesn't work. And know that many women with an epidural really can't control their lower half. They can't walk or move their lower extremities. So sometimes we'll place a catheter in the bladder to drain urine. And if we ever have to reposition her legs, we as the nurses literally have to take her legs and help her reposition them because she cannot move them. A couple things I do want to mention also is some common side effects here are back soreness and itching. Those are the two most common side effects, but an uncommon, but a side effect you want to know about is an epidural or spinal headache. These are horrible, horrible headaches that happen when the membrane that surrounds the spinal cord is accidentally punctured. And what will happen is, the medication is really only supposed to be injected outside of the membrane, but the membrane gets punctured and it starts to drain cerebral spinal fluid. And usually within about 24 to 48 hours after the epidural, these women get this just horrible ice pick through the head, just awful headache. So when you as a nurse see someone has that headache, we always start with more mild things. We usually say, okay, let's try rest and hydration, maybe some NSAIDs or caffeine. We try all that first. But if that doesn't get better, they need something called an epidural blood patch. That's where basically a little bit of blood is injected into the epidural space in the spine where the epidural was placed. This creates a patch that stops more fluid from leaking, and it actually works about 85 to 90% of the time. So it works really well. Real quick, I saw just a brief question I thought was good. Does epidural affect the fetal heart rate? Yes, it can. If the epidural causes significant maternal hypotension, that over time will affect the fetal heart rate because maternal hypotension causes placental insufficiency. And remember, placental insufficiency usually is going to show us those late decelerations on the fetal heart rate monitor, and we should know, oh, something's going on that's causing that baby, that placenta, not to get enough oxygen and perfusion. Good question. So if that is done, turn down the epidural. Good question. Yeah, turn down the epidural so the blood pressure in the mother goes back up. Okay, so next we have regional anesthesia number 2, the spinal block. This is typically used for pain control during a planned C-section. And basically this medication is the one where it is actually an injection. We take a needle and we inject it directly into the spinal cord, the fluid of the spinal cord. And this will block pain for a couple of hours after the injection. And what's nice here is it takes effect really, really quickly. And we even sometimes use it if we know we're about to do something painful during a vaginal delivery. Say, if we know we're going to do a painful vacuum assist, we could do a quick spinal. But it completely removes pain from the lower body for 1 to 2 hours. This also can decrease blood pressure, and that can affect the fetal heart rate. So we want to monitor that. And in rare cases, again, it can cause that fetal heart rate to go down. The side effects are the same. Usually, you're going to have a little itching and sore back, but those spinal headaches can happen here too. So if someone within 24 to 48 hours says, oh, I have a blinding headache. Also, if they have like spinal stiffness or light sensitivity, nausea, those are signs, yeah, that's a pretty bad headache. Suspect this is the cause. Finally, we have general anesthesia, and this is not used often. It's reserved really in the cases where there's an emergency. But we also rarely have to use this if we cannot do a spinal or epidural for some reason. If someone has to have a C-section and they have a history of a major spinal repair and surgery and a spinal injection won't work, they have to have general anesthesia. And this isn't ideal. It causes, of course, a complete loss of sensation and consciousness. It delays how quickly the mother can bond with her baby and often really can affect breastfeeding because of that delay. Risks for this method include an inability to place the endotracheal tube that creates pneumonia and lung infections in the mother, anesthetic medication toxicity, respiratory depression in the newborn, very frequently fetal lethargy, and then for both mother and baby, the stays are going to be longer in the hospital, so not ideal. Next, this is another pretty common question you can get on the NCLEX. They're going to show you a picture, one of these pictures, and they say what 3 letters indicate what position the fetus is in. Well, let's break down what each letter means. The first letter is either going to be an R for right or an L for left. And you want to say which way is the fetus's back pointing towards, because the back is the biggest part of the fetus. So if the fetus's back is pointing towards the mother's right, we get an R for the first letter. If the fetus's back is pointing towards the left, we get an L. No big deal there. Second letter tells us what part of the fetus is going to come through the birth canal first. O stands for occiput. O basically means head. If we're occiput down, that's good. We hope to see that, like this one. Mentis means chin. That's not good. If that baby is chin down, as they go down the birth canal, they're going to get a lot of facial trauma. So that's something we want to know ahead of time so we could maybe correct that position. Finally, S is for sacral, and sacral means butt, basically. If the baby is sacral or butt down, we need to know that we should not attempt this delivery vaginally. This really should be a C-section. This is not safe. Finally, what is that third letter? Well, the third letter tells us a little bit more about what direction the fetus's back is pointing. If the fetus's back is pointing towards the front, you get an A for anterior. If the fetus's back is pointing towards the back, you get a P for posterior. And then if the fetus's back is pointing directly towards one hip or the other, you get a T for transverse. So pretty straightforward. That would be a pretty straightforward question. Something else you do want to know is station. When we're giving a report, if we have a patient in labor, this would always be something we would share. We would say the baby is at something station. And what you want to know is 0 station is the most narrow portion of the pelvis. It's where these ischial spines are. If the fetus is above or a negative 0 station, it means it's higher up in the birth canal. It's going to take longer for that baby to be delivered. If we have a positive station, definitely if we have a +3 station, I would be preparing to deliver that baby pretty quick. All right, next I want to talk about the stages of labor. We've talked about the different types of deliveries, but what happens in vaginal deliveries? If we were a nurse, what should we be looking for and expecting? Well, first is the first stage. This is where labor begins. This is the beginning of contractions that are starting to cause cervical changes or dilation. And it ends when the cervix is fully dilated to 10. So the first stage is all about that cervix dilating. And it's actually further divided really into 2 main phases. There's the latent and active phase. The latent phase is where the cervix is dilating from 0 to 6 centimeters. This is slow, it's very unpredictable. And so if you have a patient in labor and they're before 6 centimeters, they're only maybe 5 centimeters, I would think in my head, I've still got time. They're probably not going to deliver for a while. But if we're in the active phase, that's the dilation from 6 to 10 centimeters. This gets much faster. It's much more predictable. So once they're in this range, I'm really preparing for delivery happening pretty quick. And do know that a lack of any cervical changes for 4 hours or greater, if the contractions are good contractions or adequate, we call them, that indicates an arrest of labor. So if the contractions look like they're normally supposed to, but nothing is happening to the cervix, that's an arrest of labor. We can also define this by if the contractions are not doing what they're supposed to, they're kind of irregular and not the perfect contractions, and there's no change to the cervix for 6 hours, that is also an arrest of labor. And really, statistically, what we know about both of those scenarios is this person probably is not going to be able to go into spontaneous labor on their own. We can consider potentially trying induction, but there's a good chance we need to have a conversation about we might have to do a C-section. Your cervix might not dilate even if we give it medicine. The second stage is where the cervix is finally fully developed to 10 centimeters, and it ends when the baby is fully delivered. And the fetus will actually pass through the birth canal with 7 cardinal movements during the stage. And that's what I'm going to talk about next. And I'll try to go fairly slow for this. So the first movement is engagement. This happens when the widest part of the baby's head passes through that pelvic inlet. That's zero station, or that most narrow point of the pelvis that we talked about before. Engagement means we're moving into the more active, steady descent down the birth canal. Next, we have descent and flexion, and these happen at the exact same time. As descent is happening, the baby's head is moving through the bony part of the pelvis, that ischial spine, and they're doing that slowly. Flexion is also happening, and with flexion, as they're moving down, their chin is pulling towards their chest to get ready to go through the birth canal. So those two happen at the same time. Next, we have internal rotation. This is where the baby will actually rotate the head and body from side to side and front to back to navigate through the more narrow portions of the pelvis. So I always say this is like the wiggle worm stage, where the fetus is like wiggling back and forth and they're getting further down the canal. Next, we have extension, and extension is the delivery of the head, face, and chin. It's extending out of the vaginal opening. Next, we have external rotation, and this is where after the head of the baby is born, it pauses, it's kind of facing downwards, and it pauses, and then it will slowly move 90 degrees towards one of the maternal thighs. And it has to move 90 degrees to get the shoulders and the rest of the body out. So that is finally expulsion. Expulsion is where the rest of the body follows the head. And this pushing stage usually lasts for up to 3 hours for nulliparous women, women who have not had a pregnancy before. And for women who are multiparous, have been pregnant before, it usually lasts for up to 2 hours, although an epidural can extend this a little bit. And let me tell you, pushing for more really than an hour is exhausting. These women are just exhausted. But really, there are multiple elements that determine how long the stage takes. It includes fetal size, the position, maternal pelvis shape and pushing ability, other factors like chronic health issues and age, and even prior delivery. So there's a lot of factors that decide how long it will take. The third stage is where the fetus is finally fully delivered, and it actually ends when the placenta has been fully delivered. We see this happen where, the separation of the placenta from the uterine wall basically has 3 distinct signs. First of all, there's going to be a little gush of blood from the vagina. That's the placenta detaching from the uterine wall. There's going to be a lengthening of the umbilical cord as you get more slack on that cord. And finally, the top of the uterus, the fundus, is going to feel more round or globular as the placenta detaches. Typically, spontaneous expulsion of the placenta takes anywhere from 5 to 10 minutes. That would be the norm. If it is taking more than 30 minutes, that's not good. The risk of postpartum hemorrhage increases a lot. And the provider will often assist with the placental delivery. And the ways they'll assist is they might gently pull on the umbilical cord while applying fundal pressure. And even in some cases, if there are a lot of clots or that placenta, they're having trouble removing it, they might reach in with a full sterile glove and actually scrape the inside of the uterus to clear the placenta and clots. And that is important. You don't want to leave that behind because that causes more bleeding. Finally, we have the fourth stage. This is the first 1 to 2 hours after delivery. And during this time, the provider is often repairing any lacerations or tears that might have occurred. Just so you know, typically all sutures used here are self-absorbing and usually dissolve by the time the woman comes back in for her postpartum visit, which is usually in about 6 weeks. During this time also, really the goal is to monitor the mother and closely watch for signs of hemorrhage, of infection, of uterine atony, and simultaneously we're going to be doing prelim assessments and treatments on the baby as well. So let's do another question together. So this question says, the nurse is taking care of a client in the fourth stage of labor. She notes that her fundus is firm, but she is still bleeding profusely. What should the nurse's first action be? And we didn't go through this in detail yet. So this is supposed to be a pretty hard question, but we're going to talk through it together. So the answer here is C. So a lot of you got that right. Totally okay if you didn't. Remember, we didn't talk through all this yet. So what's going on here? Well, if someone's in the fourth stage of labor, the placenta and baby are fully delivered. If they start bleeding profusely and the uterus or the fundus or top of the uterus is firm, I don't want to waste time doing B. If the uterus were boggy and soft and not firm, I would do B, because if the uterus is atonal, it's lacking tone, massage helps it contract down on bleeding vessels. What this question is telling us is the uterus is already doing its job. It's contracting, it's firm. Therefore, there's another cause for the bleeding. And if someone is bleeding profusely, we will never waste time documenting. Little tip, if it's a priority question, documentation is probably always the wrong answer. And she's not showing signs of hypotension or shock yet, so we don't need to do D. What we need to do is do C. This is one of those rare occasions the provider needs to get involved, because what they want you to know is this person likely has a laceration, either in the birth canal or the cervix or the uterus, and the doctor needs to know about that and potentially emergently take them to surgery. All right. So now we're going to get to some of our big conditions, and there are a lot of different conditions, but these all tend to show up quite a bit on the NCLEX. And our first condition is placenta previa. This comes up a lot because it's a pretty serious deal. A normal, healthy placenta should attach here at the top or the fundus of the uterus. It's far away from that birth canal. In placenta previa, the placenta is attaching over the birth canal, and that creates a problem. The fetus cannot get through without causing trauma and hemorrhage, which can lead to death if we don't recognize this quickly. So usually the first thing we hear about is the patients calling us saying, hey, I'm not having any pain or anything, but all of a sudden I'm having a lot of bright red bleeding. Okay, we should worry about that. If a woman suddenly has a decent amount of bright red bleeding, we should think right away placenta previa. These are classic symptoms. It's painless because the cervix really has very few nerve endings. They're not going to feel the trauma or irritation. And it's bright red because the bleeding is happening right here at that vaginal opening. It's bright, fresh red blood. And the reason this is important, it's the opposite of placental abruption. Abruption is extremely painful and it's dark red, and we'll talk more about that. But again, if you have someone calling and saying, I all of a sudden am having painless bright red bleeding, we should immediately say, how many pads are you going through and how long? How many pads in an hour is a good question. How saturated are they? I would also want to know how many clots in the color. And then right away, I want to get them in the office for an ultrasound because I want to know, is it previa? If it is previa, is it complete or partial? What's going on? But definitely, if you have someone in the office saying this, never ever do a vaginal exam. If someone is pregnant and bleeding, do not do a vaginal exam. It could end up irritating the placenta or the uterus, and it could cause worsening of a hemorrhage. So we don't want to do that. What we're going to do is, as soon as we know we have an active bleeding placenta previa, so we're going to send them to the hospital, and the nurses in the hospital are going to continue to monitor for blood loss. They're going to stay on the unit, and we're going to continue doing pad counts, and we're not just going to guess how much blood they've lost. That's what we used to do. Obviously, it wasn't very accurate. Nowadays, we weigh the pads, and 1 gram equals about 1 mil of blood loss. So we can guess, okay, based on how much they've lost, this is what we should replace. We're going to put them on bed rest. This can really slow the amount of blood loss. And we're definitely going to monitor that baby, because if there's excessive blood loss, we can start to see signs of fetal distress, and that should tell us that the fetus isn't getting good perfusion. And typically the treatment here is we're going to do a C-section. That's the only safe way to deliver. All right, next we kind of have that similar but very different condition, abruptio placentae, also known as placental abruption. This is where the placenta is where it's supposed to be. It's at the fundus of the uterus, but it will start to tear away from the wall of the uterus and detach. And that is incredibly painful. These women cannot hide their pain, and it causes massive amounts of dark red bleeding because the bleeding has a lot of time to oxidize because it's happening way up in the uterus. And know that there are two types, there's incomplete and complete. This would be an example of incomplete. Just a small portion tears away from the wall. What happens with an incomplete tear is blood will start to fill this opening, this gap, to the point where over time the uterus becomes very firm, really hard as a rock. And given more time, the abdomen itself will start to feel hard as a board. I have had these patients. I've had them come into the ER. You do an abdominal exam. If you get no give when you press down, you should worry about a lot of internal bleeding. That's very alarming. With a complete abruption, the entire placenta will tear away from the wall. That is very bad. Basically, there's massive, massive amounts of external bleeding, just torrents of blood. And we should be alarmed and act fast in that situation. And definitely know that assessment wise, these people are sick. First of all, they're going to have the dark red bleeding and intense pain. But if they have that board like abdomen and rigid uterus, we should think internal bleeding. No matter what, it's eventually going to cause hypotension and eventually shock, which will cause maternal tachycardia, which then leads to fetal distress and eventually can lead to fetal death. So we definitely want to watch that fetal monitor. And if there are any signs of distress, we're going to do what we call a crash C-section. We go tearing through the halls to get to the OR to do that surgery as quick as possible. And we always, at least in the hospital I worked at, had an OR that was set up specifically for this type of surgery. It was filled with lots of blood products in case there was a major hemorrhage situation. But we're going to continue as the nurse to monitor the bleeding. One thing we want to do is we want to monitor changes in fundal height. When we measure fundal height in pregnant women, we're measuring first at the symphysis pubis or pubis symphysis, and we measure from that point to the fundus of the uterus. And women in weeks should measure, or in centimeters, measure where they are in weeks. So a woman, say at 36 weeks, should be about 36 centimeters. Pretty simple. But usually these women who are internally bleeding will measure crazy high. Like at 36 weeks, they'll measure 52 centimeters, and that should be a sign this is some pretty advanced internal bleeding. But often we're going to be giving lots of blood and IV fluids and crystalloids to keep the blood products up, and we're going to usually have to do a C-section. Rarely, sometimes these women have to get hysterectomies as a last resort to control the bleeding, which is sad, right? Because they can't have kids in the future. But this is a medical emergency. It's very, very serious. So we have another question, and this one says, you are triaging a new client in the antepartum unit. They tell you that they started bleeding this morning and were told to come in by their OB. They deny any pain or other symptoms. Which of the following nursing interventions do you anticipate initiating? And this is a select all that apply question. Beautiful. Yeah, absolutely. Very, very good. It is going to be A, B, and E, and that's mostly what I'm seeing. So remember, if we see, okay, there's no pain, but there is vaginal bleeding, we should pretty much automatically think this is probably placenta previa. And in previa, we put them on bed rest if they're actively bleeding. We do pad counts and we do ultrasound to know what's going on. We cannot do a vaginal delivery. That's not safe. And we also can't do vaginal exams. That's not safe either. So very good job. Okay, let's try another one. So which of the following signs and symptoms are expected for your patient experiencing placental abruption? And this is another select all that apply. Good. Yeah, it's going to be B, C, and D. It's not painless bleeding. If we have abruption, it's going to be painful, trust me, but it's going to be dark red, that oxidized blood. It's going to cause hypotension. And if there's internal bleeding, we're going to have that rigid abdomen. All right, next let's talk about another very serious medical emergency, a prolapsed umbilical cord. This happens when the umbilical cord actually slips through the cervix and into the vagina after the membranes or the bag of waters have ruptured, but before the baby has fully descended into the birth canal. And eventually, what can happen here is the prolapsed cord will be compressed, usually by the head of the fetus, as it's going down the canal, and this will cut off oxygen entirely. And potentially, we have minutes to act and save this baby. So, first, we've got to see what's going on. So, if it's already slipped out through the vagina, there's obviously something there that shouldn't be. It's a very globular like piece of tissue. It's very, very soft, and it's usually blue and pulsating. It will obviously not be a normal structure. If you feel it though during a cervical exam, that's usually what happens. Again, it's a soft glob of tissue is the best way I can easily describe it, and it's usually pulsating. And typically the mother, especially if she doesn't have an epidural, will feel like there's something inside the vagina that shouldn't be there. But again, if this is going on, first of all, never ever attempt to push that cord back in. It kind of sounds like a good idea. I'll just quick fix this. It will not fix it. It will go bad. The umbilical cord is a very friable, delicate piece of tissue. If you try to jam that back in, it will rupture and hemorrhage and bleed like stink. So don't do that. What you want to do is help that cord send oxygen to the fetus by holding the fetus's head or whatever the presenting part is up off that cord. And you can't just hold it for a little bit. You got to hold it really until the situation is resolved. So if you're the only one in the room, hold that head up and scream for help. You need help in the room. And the other nurses should help you put the mother in a knee to chest position. That's going to open up her pelvis so you can lift the head up more easily. We're going to put her in the Trendelenburg. We're going to move or shift gravity of the baby off the cord. We're certainly going to put oxygen on the mother. That's going to help send oxygen to the fetus. And finally, we're going to wrap that cord in a sterile, moist towel. And eventually, she's going to have a C-section. We can't safely get that baby through the birth canal without causing worsening of the situation. So we have to do C-section. All right. Shoulder dystocia is next. This is also a big emergency when it happens. And basically, this is a condition where one or both of the baby's shoulders actually get stuck either behind the mother's pubic bone or the sacrum during birth. And this leads to severe complications, including nerve injuries to the baby and all the way up to fetal death and maternal death. This is really a medical emergency when it occurs. Interestingly, this comes from the word dystocia. Or I should say the word dystocia comes from the Greek words dis or difficult or tokos, and tokos are birth. So it means difficult birth. And this is a difficult birth. And really where we recognize this happening is during that second stage of labor where the baby is being delivered. There is typically a pause after the baby's head is delivered before the rest of the baby is born. There's that rotation to one of the sides. But if that pause is longer than normal, we need to act on that fast because that could be a dystocia. Again, it's a medical emergency. This occurs in about 1 out of 200 births, and it's more common, of course, during vaginal births. Technically could happen during a C-section as well. Again, why do I say this is a medical emergency? Well, the umbilical cord might be squeezed during this. This can cause a fracture of the collarbone. This can cause nerve damage. This can cause brain damage. It is severe. So, what are risk factors? What women are more likely to have these? Well, actually, the single most common cause is the use of a vacuum or forceps delivery. Typically, if you're having to use those, the baby was not being delivered easily already. But when you use those, it's really easy to pull the wrong way and accidentally wedge that baby in the wrong position more forcefully. And that can really get them stuck. And that's not good. Macrosomic or big babies, of course, are at risk for this. Fetal malposition is a problem. Maternal malposition, if the mother is not laying in the right position with an open pelvis, there can be issues. A narrow or abnormal pelvic opening is also important. I've had patients who, at their very first exam when they're newly pregnant, I can say, you shouldn't have a vaginal delivery because some women naturally have an abnormally narrow pelvis and they just won't have a successful delivery. They need to have a C section. Maternal obesity is also a risk. Also, excessive weight gain during the pregnancy can increase this risk as well, as can maternal diabetes. That tends to increase the size of the baby. Short stature is actually a big risk, especially women who are under 4'11". That's a big risk. Advanced maternal age increases the risk, and finally, epidural risk. Epidural use can also increase the risk as well. What's frustrating, though, I will say, is these risk factors may slightly help with predicting shoulder dystocia, but the truth is, this usually happens without any obvious risk factors. It happens when you last think it will happen. It's very, very hard to predict. So just always be prepared for this and ready to act. So, what are the complications? Well, in the mother, it can cause very severe tears or lacerations. Most women will typically have first or second degree tears after a vaginal delivery. They're not fun, but people heal from those fine. They're usually about 1 to 2 centimeters in length, respectively. These women tend to get third or fourth degree tears, which are horrible to recover from. A third degree tear extends from the bottom of the vagina almost all the way to the rectal opening, and a fourth degree tear extends all the way from the vaginal opening to the rectum. You have one continuous tear that's hard to repair and it's very hard to heal from. Of course, you can get hemorrhage and infection because of this. It can also cause severe damage of the nerves, especially, like I said, those women who are getting third and fourth degree tears. Man, that causes horrible nerve damage, which can cause lifelong fecal and urinary incontinence. I will say, though, newer physical therapy techniques do tend to help a lot with that. It can also cause a rectovaginal fistula, which is an abnormal tunneling or connection between the vagina or rectum. And this causes a lot of complications, of course, like infection and sepsis and needs surgical repair. It can cause uterine rupture, which we talked about before. And it can actually cause complete separation of the pubic bones in the front or back of the pelvis. That is horrible. Very, very hard to recover from that. These women, if they have pubic bone separation, even shifting their weight is excruciating. It's very painful, very long recovery. In the fetus, they can get brachial plexus palsies or injuries. These are the most common, and they stem from trauma to the neck and really lead to a lot of pain and weakness of the arm and hand. And this occurs in about 1 out of 1,000 births. But the good news is most babies recover from this with physical therapy over the course of about 3 to 12 months. These babies can have fractures to the clavicle or humerus, like both sides. You can be fractured from one delivery. You can get Horner syndrome. This is a rare neurological syndrome that affects the eye and surrounding area on that side of the face. if there was trauma in that area. And basically it leads to drooping of the upper eyelid. Usually there's pupil constriction, and usually these people can't sweat in that area of the face. Lifelong issue. And then finally, it can cause a compressed umbilical cord. And of course, as we just discussed, that's a medical emergency that can go bad in minutes. So, how do you tell really if someone has shoulder dystocia? Well, it's diagnosed on three main factors being met. First of all, the baby's head has to have been delivered, but the mother isn't able to push out the shoulders. That part is stuck. That's part one. Part two, at least 1 minute has passed since the baby's head was delivered. That's when we should start to sweat a little bit. You do not wait too long. I have people who say, yeah, I usually give them 5 minutes. That's too long. It really, wait a minute. If the rest of the body isn't delivered, we need to be doing things to help them deliver the body. Finally, if the provider determines, hey, this body is not going to come on its own, I need to intervene, that's the definition of shoulder dystocia. There is also a sign that's suggestive but not diagnostic called the turtle sign. And that's where the baby's head was delivered. And what will happen here is the head will emerge and then pull back really quickly. So if the head goes out and then pulls in like a turtle, that's the turtle sign. All right, so what are the interventions? Well, first of all, if you for some reason were alone in the room, you shouldn't be during a delivery, although it can happen as an L&D nurse. But even if it's just you and the provider in the room, call for help. This is a medical emergency. You need more than two people. You need to be really working as a team to resolve this quickly. Evaluate for episiotomy. This is one of those situations where it's better not to wait and just let them tear. We need to open up the pelvis to resolve this quickly. So an episiotomy actually is appropriate here. Legs stands for we're going to reposition the legs. This is where, with the help of the nurse, especially if they have an epidural, we're going to basically have to hold their legs up for them. But we're going to do what's called the McRoberts maneuver, where the maternal thighs are pressed up against her abdomen and she kind of hugs them, and it helps to rotate and flatten the pelvis. And sometimes that releases the shoulders. Pressure stands for exerting suprapubic pressure just over that pubic symphysis or mons pubis. So typically while the mom is holding her legs up, the provider or nurse will then press that lower abdomen above the pubic bone, and hopefully that's going to push the shoulder out of the way to help rotate and deliver it. So that's the next thing we do. Next are enter maneuvers. This is where the provider sterilely will reach up into the vagina and try to turn the baby, shift the head, shift the shoulders, all of that. Remove the posterior arm. Next, the provider will basically try to pull out one of the arms and release it, making it a little easier for the shoulder to pass through. Finally, we have roll the patient. This is also known as the Gaskin maneuver. And basically, with the help of nurses, we're going to roll her onto her hands and knees, hopefully, again, opening up the pelvis and shifting the baby. But sometimes the baby is still stuck. That's where we're really getting nervous, because then we have to do some pretty extreme additional maneuvers. What are those? Well, we might deliberately fracture one of the newborn's clavicles. Remember, the shoulders are stuck. This could be compressing the umbilical cord. This needs to be resolved quickly. Well, fracturing a clavicle will do that. We don't want to do that, but sometimes we have to. The Zavanelli maneuver is where the provider will say, hey, we're out. This baby won't be delivered vaginally. They'll push the baby back up into the uterus and go do a C-section. Finally, this last one is very extreme. It's a basically they cut the pubic symphysis. They do a pubic separation. And basically, we emergently take the person to surgery, and we cut the cartilage between the pubic bones to open the pelvis. and release the shoulders. Again, that is a horrible recovery for that mother. So we do not want to do that if we can avoid it. But one big thing you want to be aware of is if there's shoulder dystocia, do not, absolutely do not apply fundal pressure. This will significantly increase the risk of uterine rupture. The baby is stuck. Pushing from the top is only going to put more pressure in the uterus. What we want to do is actually tell the patient, stop pushing until this is resolved. Again, we want to minimize the intrauterine pressure. So this is where it's nice to just have one nurse who's able to help coach the patient to breathe through her contractions to resist pushing, because it's hard to not to push if you feel like you need to push. And then just remember too, this is similar to a code. This is a big emergency. If you have the staff, also have a dedicated nurse who can document when did this start, what techniques did you do to resolve it, when was the baby delivered, and were there any adverse events, because this is essentially creating a legal document that's very important. We need to show we did the right things in this emergency. So the next labor and delivery condition I want you guys to be familiar with is chorioamnionitis. This is a condition that is very serious. And again, we need to recognize it quickly when it happens. And basically, this is when the membranes that surround the fetus are actually infected by bacteria. And this leads to really bad complications, both for the mother and the fetus. It actually gets its name from the two membranes surrounding the fetus. There's the chorion, that's the outer membrane, and then there's the amnion, which is the inner membrane. And this occurs in about 1 to 5% of births. So in the US, it does, and it's a major cause of preterm birth. So if you are you guys able to? Okay, perfect. Just want to make sure you can see my screen. So basically, if you work in labor and delivery as a nurse, guarantee you're going to see this a lot. And it's usually caused by a bacteria from either the vagina or rectum that then spreads to the uterus after the water breaks. This is especially risky if she's getting too many cervical checks after the water breaks and she's, dilating. That can definitely add a lot of bacterial exposure to that amniotic space. But you can actually have this too in early pregnancy after someone gets an amniocentesis. That's very rare. Remember, an amniocentesis is a diagnostic test to assess for congenital abnormalities usually. No two for the organism. Usually it's either group B strep or E. coli, but rarely this can be caused by group A strep or strep A. And man, that's bad. This is very rare, but it's very difficult to treat and sometimes fatal in both the mother and baby. And so people with strep A are in the hospital, sometimes for weeks, getting fluids and antibiotics. That's a big deal. And symptom-wise, over here, the main symptoms in the mother are going to be fever. Fever is really the big, most important clinical sign. Even a low-grade fever around 100 degrees Fahrenheit, that's not concerning. But if you're getting persistent fevers of 100.4 or above, there's multiple readings of that, I would be concerned. Or if you get any reading over 101, even one, I would say, yes, I think this person probably has chorioamnionitis. It also causes severe maternal and then eventually fetal tachycardia because of the infection. It causes a severely tender uterus. Something that we always do as part of the assessment in labor and delivery is we assess the fundus or the top of the uterus. These women, you press it and they practically leap off the table. And then it also tends to cause quite a bit of extravaginal discharge, abnormal smelling, and looking lochia, typically with a foul smell. However, what are going to be the main tests we want to do? Well, that's over here. One of the first tests we're probably going to get back is the CBC, and typically we're going to see, hey, those white blood cells are pretty elevated. Really, if they're over 15,000, I would investigate, especially if there's that shift to the left. Remember, the left shift with white blood cells is what happens when there's an increased number of the immature cell types in the blood cells, and that happens if there's a new infection. So, especially if you see all of a sudden there are a lot of neutrophils being created, I would suspect there's a new infection. But actually, the gold standard test is this culture. We're going to do a swab of the vaginal discharge, send it out for a culture. That takes usually a day or two, and it's going to tell us what type of bacteria we're dealing with. Most good cultures should also tell us what are the best antibiotic agents to choose based on that. But while we're waiting for the culture, typically we'll do a gram stain. That's something the provider, someone like myself, can do. You do what's called a wet mount. You prepare a little discharge with saline on a microscope slide, and you just look at it under the microscope. And I would expect to see a lot of extra abnormal bacteria, a lot of white blood cells, because the infection is going to cause inflammation. And then finally, we might just look at the amniotic fluid as well. What are the complications? Well, like I said, this is not good. First of all, it can lead to further infections of the pelvic region or abdomen, especially endometritis. Endometritis happens fairly often to women in the postpartum period. Her uterus, the lining or endometrium, gets a really bad infection. And these women, again, they go home, they feel okay at first. They start to feel run down, they get a fever, they get achy, they start to get abnormal discharge and pelvic pain, and it's really not fun. They're also at higher risk for blood clots. Any infection, just so you know, puts people at higher risk for clotting. And then it can also cause sepsis if we don't catch this soon enough. For the baby, it can also cause sepsis. Specifically, it can also, it's known to directly cause meningitis and pneumonia as well. And really, both the mother and baby, they're going to need an IV and IV antibiotics. And typically, the baby is going to stay for a couple days, at least a day longer than they normally would for closer observation. All right. So we talked about this earlier, but a really big complication in the postpartum period is postpartum hemorrhage. They want you to know this on the test because it's common and it's very serious when it happens. So first of all, what are the risk factors? I have two slides on this because there are some extra ones I wanted to add in the next slide. So the main risk factors are these: twins, triplets, is going to cause typically more bleeding because there was more than one placenta attached in the uterus. There's more sources of blood. Macrosomic fetuses or big fetuses cause more trauma and therefore more bleeding. Preeclampsia or any high blood pressure state causes more bleeding. And also what's interesting is prolonged or precipitous labor. If it's too fast or too slow, it causes prolonged bleeding. I always tell people labor is kind of like Goldilocks and the Three Bears. It has to just be right. And that's a big part of what the nurse is doing, managing the pace and monitoring for this. But labors that go too fast, usually there's a lot of trauma and bleeding. Labors that go too slow, often that's because the placenta won't detach normally, which leads to bleeding issues. If the provider had to use forceps or a vacuum, that tends to lead to more bleeding. Or, of course, placenta previa or abruptio placentae would be causes as well. There are a couple additional ones here I wanted to note. Also, polyhydramnios is a risk factor, excessive amniotic fluid. A recent bleeding history. So if they have a clotting disorder like von Willebrand's, where they bleed really easily, we want to know about that. I would also want to know in prior deliveries, in prior postpartum stages, did they have postpartum hemorrhage? Because people who've hemorrhaged before are likely to hemorrhage again, more likely to. And then uterine fibroids, we talked about those early. Remember, those are those benign tumors that a lot of women have. They grow on the uterus and they increase in size and amount with age if you have them. And when women are not pregnant, fibroids cause heavy, long periods. They cause a lot of bleeding. They also cause a lot of bleeding with labor as well. And then finally, Interestingly, multiparity tends to lead to more postpartum hemorrhage. Women who have not been pregnant or had a delivery before, less likely to bleed, which I find interesting. All right. So, next, what should we do for the assessment? Well, you guys already did a question on this, so you probably already know a bit of this. But remember, we want that nice firm uterus. If we feel a boggy or atonal uterus, that's a uterus that's not contracting to clamp down on those blood vessels. And the fundus usually feels soft. And also, the fundus is usually too high. Within a couple hours after delivery, the fundus or top of the uterus should be at the belly button or below, and usually it goes down about a centimeter a day. If it's well above the belly button, I'm worried again, it's not contracting like it should. So I want to know about that. We're going to track blood loss, certainly. If we notice, hey, someone's bleeding a little heavier than they should start doing pad counts. And postpartum hemorrhage clients typically are saturating a pad every 15 minutes. So they're saturating 4 pads an hour. That's a massive amount of blood. And also, if you get called into a room, someone says, something feels weird in my bed, you pull back the cover and there's a big puddle of blood. Trust me, they're very likely hemorrhaging. Call for help. If they try to stand up and they're losing massive amounts of blood, they're actively hemorrhaging. Go ahead and put that call light in to bring some more people to help and start helping that person. And these people can develop shock very quickly. Remember, they're losing blood very, very quickly, and this leads to hypovolemia. So, what are some of those advanced signs? Well, I've had this. I come on to a shift, go to assess my patient, can't arouse them. If they're not getting enough blood to their brain, they'll have a very decreased level of consciousness. They're often pale and very diaphoretic or sweaty. Their blood pressure is very low. Heart rate is very high. So if we're in a situation where the uterus, they're maybe not actively hemorrhaging, but the uterus feels really soft and it's not where it should be, you could probably just start out with some fundal massage. That's an appropriate first response. But you're not going to be nice. You know, you got to warn people, I'm not trying to be mean. This is going to hurt though. I need to contract this enough so it starts, or massage this enough so it starts contracting down on the bleeding vessels. And you're not just going to do it once, you do it every 15 minutes until you feel like that uterus is firm. But we're going to continue to track blood loss. Remember, we're not going to guess, we're going to weigh the pads. And we're going to track trending serial hemoglobin and hematocrit as well, or H&H, because usually those trend down pretty quickly, and we need to know when we have to give blood products. Typically, people can get really low before we treat that in women's health. Usually, unless they're very symptomatic, we wait till the hemoglobin is less than 7, very, very low. But we will use them if needed. But if we're getting into a position where they're starting to bleed really heavily, they're actively hemorrhaging, we're probably going to consider giving them oxytocin. Remember, that's the medication that turns on the gas. It increases the contractions to help stop the bleeding. Methylergonovine is a medication that's similar to oxytocin. Methylergonovine is in a group of drugs called ergot alkaloids, and it actually affects the smooth muscles also of the woman's uterus, helping it to contract more strongly and rhythmically. Typically, methylergonovine, we use it for postpartum hemorrhage, but in labor and delivery, we typically use it if the placenta isn't delivering. We'll give this and it will help to deliver the placenta, also called the afterbirth. Okay, so let's try another question. So this says, okay, the client in the delivery room has just delivered her 3rd child. The physician ordered methylergonovine or methergine for the client and it was promptly administered. Which manifestation would indicate to the nurse that the medication is having its intended effect? Absolutely. So we should be picking B. Exactly. Very good. So methylergonovine promotes vasoconstriction and uterine constriction. So the sign we would expect to see is that it's nice and firm and constricted. That's good. Exactly. Very good. All right. So next condition we're going to talk about are actually breastfeeding issues. Like I said before, breastfeeding is not easy for most people. We think about most mammals, most animals or creatures that drink milk, and it appears to be this very natural, easy thing. The animal gets up, walks over, and immediately starts suckling. It is not that easy for humans. Usually, it's very difficult to get the right hold and the right latch and all kinds of factors. So, this is a point of frustration for a lot of women. And if there continue to be a lot of breastfeeding issues, a bad outcome or complication we see a lot is mastitis. And basically, mastitis is where one or more than one of the lobes of the breast become inflamed, often because of an infection. And wherever that inflammation happens, you have pain, you have a lump. It's really, really uncomfortable. And you can see the nipple is where you have the opening to the ducts. If you have bacteria travel into one of these ducts, it's going to infect and inflame that entire lobe. So, like I said, it's inflammation of the breast tissue, often caused by an infection. It causes severe pain, swelling, breast lumps, warmth, and redness of the breast. These women often are so tender. When I examine them, I just lightly touch their breast. They're like, "Ow!" They can't contain the pain. If one of their breasts is affected, they can't lay on that side because it's so painful. Women will also, though, have these systemic flu like symptoms. As the infection advances, they have severe fatigue, really high fevers that leads to body aches and chills, headaches, nausea, vomiting. These women are really sick. Like they cannot get out of bed, shaking, racking with chills, in a lot of pain and discomfort. And really, an advanced mastitis, it can actually also lead to lymphadenopathy. The axillary nodes can get inflamed. Even the subclavicular nodes can be swollen as well. So, risk factors, the big risk factor is breastfeeding, especially if there are issues with latch techniques. So often, I have patients who are like, "Yeah, this is really hurting when my baby latches, but I want them to eat. I'm just going to deal with it. I can suffer through the pain." And I say, "Don't do that. It sounds like you're being stoic and you're doing everything for your baby. That's not going to work out in the long run because that improper latch is going to cause nipple trauma, which will lead to sores and cracking, which will lead to an infection. And trust me, if you get mastitis, you're not going to be able to breastfeed effectively because you're so sick. And it also tends to decrease milk production on the side of the infection. So I always tell women, hey, as soon as you know that latch is wrong, you want to use your finger, break the seal in the baby's mouth, and help them relatch. I always tell people you want to splay open the mouth and lips as wide as possible. You want that newborn to take a big bite over the nipple, and that's a good latch. And then also tell her, don't wear tight fitting bras and clothing that can restrict milk flow. It needs to be snug, but not too tight. Breast implants also create a lot of issues. People with diabetes or autoimmune diseases get this more. Same with people with eczema or skin conditions. Nipple piercings is a big cause. I've had a lot of conversations with people. It's like, yeah, I know you want to keep your nipple piercing, but honestly, if you want to breastfeed, you might want to consider that. I don't want you to get an infection. Nicotine and tobacco use really increases the risk for this. And then nicks or cuts in the skin from women who pluck or shave the area are going to get this more as well. So, what are the types of mastitis? Like I said, lactational mastitis is by far the most common. This is what affects breastfeeding women. It's also known as puerperal mastitis, which means relating to childbirth. And it's most common occurring sometimes multiple times in the postpartum period. I've had patients who have had mastitis over and over and over several times to the point where sometimes women just say, I'm done, I'm done breastfeeding. And it's very frustrating for them. There's also periductal mastitis, and this is more common in menopausal and postmenopausal women, but we also see this again in smokers. And it's basically also known as mammary duct ectasia, which is a condition where the milk ducts really thicken, and that leads to inflammation and infection. And sometimes the nipple and the affected breast may also invert and produce a milky discharge. Do you know? I'm always really wary about these periductal forms of mastitis. Mastitis does not increase the risk of cancer, but it can mask cancer signs and symptoms. Periductal mastitis often looks very similar to that inflammatory mastitis. So if I'm not pretty certain of what I'm dealing with, I'm probably going to do further testing just to make sure I don't miss some major cancer. Well, how is it treated? Well, typically it's a bacterial infection that we're going to treat with antibiotics. Dicloxacillin and Keflex are two nice broad spectrum antibiotics. And I always tell people this is not the most fun to take. You have to take these 4 times a day for 10 days straight because it takes a lot of time in large doses for antibiotics to penetrate the breast tissue. I always tell these women, you're usually going to feel better in the first 1 to 2 days. Please do not stop taking your antibiotics because it's just going to come back right away. Additionally, they want to do warm compresses and warm showers. That helps to open up that those inflamed ducts so they can release milk that's trapped in them. They want to frequently breastfeed and pump. Again, we want to release the trapped milk. And ideally, when they're breastfeeding, they want to gently massage the area. Use of OCP or OCT medications like NSAIDs and acetaminophen are very important. The acetaminophen really helps with the fever management, but the NSAIDs are so important because remember, NSAIDs reduce inflammation. This is an inflammatory process. So reducing inflammation is both going to reduce pain and it's going to open up those milk ducts to allow trapped milk to get out. So we want that. And then finally, they need to wear nice supportive bras that don't compress the breast tissue. But so many women are so fearful about breastfeeding while experiencing an infection. They don't want to give the infection to their baby. They don't want the antibiotics to hurt their baby. They need to know it's important they continue to breastfeed. It's totally safe for the baby. It's been well studied, very, very safe, and that's the best way to treat the infection. I should mention too, they want to feed pretty frequently. When they actively have an infection, ideally every 2 to 3 hours to really get that trapped milk out is very key. The longer that trapped milk stays in the breast, the more likely these women are to develop abscesses, big collections of purulent drainage under the skin, and those need to be drained before that woman becomes septic. What are some nursing considerations in education? Well, remember, we want to encourage really frequent feedings. We want them to avoid long periods of time between feedings, as that's going to allow milk to just sit in those ducts and become trapped and infected. The number one most common time women get mastitis, definitely for the first time, is that first night their baby sleeps a decent amount of time. They're like, yay, I got 6 hours of sleep. Oh no, I didn't breastfeed. I forgot to get up, and they have trapped milk and it can become mastitis. So I always caution, I want you to get sleep, but I also don't want you to get mastitis. I always tell women to avoid nursing pads or bras that keep the nipple moist. You don't want to use disposable pads. They tend to have a plastic backing that keeps moisture on the breast. We want cotton pads and bras. Those are best. We certainly want to encourage the mother to nurse completely on one side of the breast and empty it before moving to the other side. Remember, we don't want milk just sitting in the breast for too long. And then finally, if there's an improper latch, break that seal. That's very, very important. Good question. I had someone quick ask, could they use petroleum jelly or like lotion when they're massaging Sure. Yeah, I think that would be great. And along the lines of that petroleum jelly, there's something called lanolin cream or lanolin lotion that is specifically for breast or nipple care. It's a very, very thick, almost waxy type of lotion or ointment that you put on your nipple every time after you breastfeed, and that prevents the nipple from cracking and opening into sores. So that's a great thing to use as well. Okay, now I want to talk about postpartum depression. This is something I'm really passionate about because I think, like most areas in healthcare, it's a mental health issue, so it's not talked about enough. But postpartum depression is very, very common, and mood changes after delivery are very, very common. So often, women have this idea in their mind based on movies and television that, oh, I'm going to be floating on clouds enjoying time with my baby and relaxing. It is hard. I tell people, the first 6 weeks after having a baby, it's baby boot camp. You're not going to be sleeping well. It's going to be hard to get stuff done. People need to know it's okay if you don't have a perfect postpartum experience. But mood changes after pregnancy, like I said, very common. They're not discussed though. About 60 to 80% of women will experience baby blues. Most women will. Well, about 10 to 20% of women will experience a full postpartum depression. This is often not caused by any one cause, but a combination of factors that lead to this issue, including very rapid hormonal changes within the first couple days after birth. This is largely what's causing the baby blues. But also, if there's a personal history of depression or anxiety or family history, that will increase risk. Poor social or economic stress or support. Also, first time in young mothers, they're at high risk because remember, for many people, reality will not meet their expectations. They expect it to be something that it's not, and they don't realize how hard it is, how much support they need. So we need to help provide support to these women, of course. And then breastfeeding issues. Like I said, breastfeeding. A lot of women tend to think, oh, it's natural. It'll just come natural. It usually does not come naturally. It takes a lot of education, a lot of trial and error. So let's compare what is the difference between the baby blues and depression. Well, the baby blues usually occurs within the first 3 days and lasts for about 2 weeks, but it's self limiting. After that first couple weeks, people will start to improve. It's expressed though with frequent and prolonged crying. 1 minute they're fine, and all of a sudden they're like, "I don't even know why I'm crying. I'm just crying." It's just hard to control your emotions. It can also cause irritability, poor sleep, and definitely a sense of vulnerability. Mood changes are rapid, so it's very hard. But there are not thoughts of suicide or death. That's one main feature you want to know. Depression is very different. It's much more debilitating and much longer lasting. And basically, if symptoms are lasting longer than 2 weeks, it's postpartum depression. It's no longer the baby blues. And this is expressed with feelings of severe despondency, tearfulness, very intense feelings, usually of severe guilt, like they're not doing enough for their baby, anxiety, fatigue, all of that. It's especially concerning if the mother says she can't bond with her baby. That's a sign of a very advanced postpartum depression. And it's also very concerning if someone says, I'm having recurrent thoughts of self harm. We need to act on that. So, next, I wanted to quick share what are some things that women who experience postpartum depression, what are they often saying to you? Well, here are some examples. They say things like, I feel like running away. I don't feel like myself. Often I hear things like, I'm a horrible person and mother. I can't do well enough. I hear things like, I feel like I'm going crazy. And then this is the one thing I hear a lot. I would never act on it. I promise I would never do this to my kids. But I've been thinking a lot about, I don't want to be here anymore. I don't want to live. That is alarming. We need to act on that. The partner, on the other hand, often they're calling the office too, and they're saying things like, I don't know what to expect when they get home or when I get home. Is she ever going to go back to the way she was? And I know something is wrong, but I don't know how to help. That's where we need to come in and help these people because it's very scary and hard. Do know extremely rarely women can have something called postpartum psychosis. This is a very rare condition that typically occurs within the first week after delivery, but not always. Sometimes this can be delayed by months. And the symptoms are severe. They include feeling severe confusion, a feeling of being lost, very obsessive thoughts about the baby, hallucinations and delusions. Sometimes they hear voices telling them to do things, severe paranoia, and sometimes it leads to attempts to harm self or baby, and sometimes those are successful. And I can say as a provider, this is my worst nightmare. If I ever have a patient who's severely depressed or showing any signs of this, I do not mess around. I send them inpatient for a prolonged stay because these women do much better with early recognition, intense, immediate therapy. So often, I see providers who try to just manage it on their own. They throw different medications at them, hoping it'll stick. If someone has psychosis, it's an emergency. You need to get them to the hospital. I'll just share briefly. You may have seen on the news, there was a big story about a woman who had a horrible incident involving postpartum psychosis. This happens. It's our job to recognize it and help these women get the proper care. So when should we recognize treatment? Well, if the symptoms don't get better in 2 weeks, that's not normal. If it's consistently getting worse, if the mother reports she's having a lot of difficulty either caring for the baby or caring for herself, I'll have women call and say, I haven't showered in a week. I can't do this. Like, I'm totally overwhelmed. I usually want them to come in. And then, of course, if there are thoughts of harming self or baby, we need them to come in. And many women are really avoiding treatment or help because they feel ashamed. They feel like, again, this is not what I'm supposed to feel. I'm supposed to be happy. But we need to tell them, no, that's not what you're supposed to feel. You feel what you feel. A lot of women are going to have this. More than half of women will have the baby blues. It's not their fault. That's why we're here to help. It's okay. So how are we going to treat these women? Well, first of all, she needs to make an initial appointment with a provider. That should involve a very thorough interview. How is your sleep? How are you coping? Do you have support? Are you taking any substances to manage this? So on and so forth. We want to do a thorough physical exam. And then I always like to do a handful of labs. I like to do a blood count because, hey, if they're anemic, that's going to worsen depression and fatigue. So I'll treat that. I want to check a thyroid. Hypothyroidism tends to cause worsening of depression. I usually check a vitamin D too, especially where I live in Michigan. People are often deficient in vitamin D, and it really is more and more in studies shown to really impact mood. There was this big study that just came out that showed in a study of people who committed suicide, 50% were vitamin D deficient. So that it does more than we think it does. So I check it. I also certainly recommend psychotherapy. Counseling is so helpful. It really is going to help her to learn coping skills. It's going to learn to help her set goals and respond to situations better. Sometimes we use antidepressants, but I never force this at all. It's how comfortable she feels with it, then I'll do it. Usually I like SSRIs. These are safe and effective. And Zoloft or sertraline is usually a first choice. There is a new medication called brexanolone or Xarelto that is the very first drug approved specifically for postpartum depression, and it's amazing. It works great. It works within hours, but we don't use it very often because it's very expensive. You have to be in a hospital receiving it IV over several hours with a provider supervising. So we don't use it very often, but I would think that would be a great option for someone with severe depression who is inpatient. Sometimes we use anti-anxiety medications. I do have some patients who have less depression per se, and they do have more so the anxiety. And for them, I use benzodiazepines, sometimes rarely. if it's severe. I encourage these women to go to mother baby meetup groups. That's so nice for them to talk to other women going through the same thing. Same with lactation support groups. It's going to help them learn to breastfeed, but half of it is just nice to be with other women going through the same thing. Okay, so postpartum complications. Finally, we have thrombophlebitis. Thrombophlebitis is an inflammatory process that causes the blood clots to form and block one or more veins, typically in the legs. And when the affected vein is near the surface of the skin, it's a superficial clot or a superficial thrombophlebitis. That's not very concerning. When it's deep in the vein, within the muscle, that's a deep vein thrombosis. That's concerning because that clot can break off and cause a pulmonary embolism. So we do need to inform women first and foremost. The risk for these issues is very high for the first 6 to 8 weeks after delivery. Real quick, I always tell people, I have so many patients who are so fearful of hormonal birth control. I don't knock you for it. You're right. It does increase the risk of blood clots, but being pregnant is a 20 times higher risk of clotting than being on birth control. Being pregnant, being in the postpartum stage is a huge risk for blood clots. So we need to tell people how to avoid them, to avoid DVTs. So, what are the risk factors? Remember, if she's pregnant or postpartum, she's at risk. But especially if she had a surgery, if she had a C-section, if she had to do a post-surgical D&C, or if she had a tubal ligation, some people will do that. You can have that done within a certain time frame after delivery if you're done having kids. A history of a blood clotting disorder. Hopefully, we already knew about that before the postpartum stage. If we did, they've probably been on anticoagulants the whole pregnancy, something like maybe baby aspirin or low molecular weight heparin. BMI over 25 is a risk. Preeclampsia or high blood pressure is a risk. Smoking, of course, is a big risk. Postpartum hemorrhage is a big risk for clots as well. Infection, immobility, two big risks for clots, no matter who you are. Increasing age is a risk. Starting birth control too early is a risk. So I always tell women, if you want a birth control that has estrogen in it, you cannot start it until after 6 weeks. That's a hard and fast rule. I won't budge on it. The risk is way too high. And then finally, believe it or not, varicose veins is actually a risk. We used to just think, oh, those just look kind of unsightly. They're just kind of annoying. No, they actually can increase the risk for blood clots. So I've had patients who have big, ropey veins, and I tell them, I think you should see the vein center. Maybe you can get those treated. What are the symptoms? Well, symptoms are going to be very similar. So if I compare these, you can see both have warmth, tenderness, and pain. Both have redness and swelling. The difference is sometimes with a superficial thrombosis, you'll feel like a hard cord under the skin. You don't see that with the DVT. It's too deep and you just have a lot of swelling. So the point I want to make with this page is don't try to just eyeball it. You really have to get an ultrasound if you're doing your job correctly, because you really want to know for sure, is this the DVT? But if someone calls the office, I would skip the ultrasound and send them right to the hospital if they tell me that the pain in their leg is really severe. Or definitely, if there are signs of a PE, like shortness of breath, chest pain, hemoptysis, I'm probably calling 911 to send an ambulance to their house. Okay, so what's the treatment? Well, first of all, prevention is a really important treatment when it comes to clotting risk. So we want to tell these women, when you go home, yes, you're recovering from your labor or your C-section, but you need to get up frequently and walk around. That's very important. And if you're going to be on a long car ride, or if you're going to sit for long periods of time, just about every hour, you want to get up and walk around or elevate your legs. They also want to increase fluid intake. And I always tell people, tell your patients to get a big jug of water and a snack basket, and they should keep that wherever they sit usually, because a lot of times, especially for new moms, it'll be the end of the day and they'll be like, oh my gosh, I have not ate or drank anything all day. I remember that happening to me because you're so focused on your newborn. So tell them, so you don't forget to drink, get a big jug and keep it by you. Some women who are determined very high risk, so people who have a known clotting disorder, people who are severely obese, we might have them go home on an anticoagulant, usually for a full 6 weeks. So that might be low dose aspirin, it might be heparin, it might be low molecular weight heparin. But we use that as a preventative as well. We use SCDs, the sequential compression devices in the hospital, and then TED hose help as well. What do you do if a clot has happened though? Well, if you do the ultrasound and it shows you, oh, it's just a superficial clot, there's not a whole lot you need to do other than say, encourage warm compress, maybe some compression bandages and elevate the limb. For a DVT, that's where we're going to do anticoagulation. And I'm not managing this. I always tell people I'm the provider for women's health related issues, but if they have a clot, they're going to have to see the internist for this, but they're going to get anticoagulants. They might need surgical removal of the clot. They might even need an IVC filter if it's a clot that can't be removed. So pretty important stuff. Someone just asked, no, nor warfarin. What would we use warfarin? Not for a short time. Warfarin is a medication that we use if we're going to have chronic management of coagulation, but it practically takes 6 weeks to get to the right dose with warfarin, and then they'd be out of that high risk period. So we just use heparin and low molecular weight heparin usually. Okay, so let's wrap up with some questions here. So a nurse is assigned to care for 4 clients who are each 1 day postpartum. Following the nurse performing an initial assessment on each client, which finding would prompt further evaluation by the nurse? Which of these concerns you? Exactly. Yeah, the answer here is D. So first of all, what are the things we don't need to worry about? Well, A, mild pain. Mild pain is expected after a delivery, definitely after a C-section. I always tell people you're going to be sore, you're going to be uncomfortable. We'll make the pain less, but just like any surgery, you have to expect some pain. The pulse, that's a normal pulse, 65. I think that's fine. I don't see anything wrong with that. And colostrum from both breasts, that's a normal finding. That's an early sign that their milk is coming in, and we want them to be trying to breastfeed when this colostrum discharge is happening, because colostrum, that first part of the milk production, has all kinds of immune benefits in it. And then finally, D, the red foul smelling lochia, that's not normal. That's an early sign of an infection like endometritis, which we talked about earlier. So I would certainly get more vital signs on that person. I would do a temperature. I would want to see if her heart rate is becoming elevated. I would do further assessments. I would see if her uterus is tender. I would call the provider and get labs and testing. So very good job. Okay, how about this one? While providing education to a group of expected mothers regarding the prevention of postpartum thrombophlebitis, you know they understand your teaching when they make which of the following statements? And remember, this is another SATA question, so choose all the answers that make sense. This is a hard one to get because all of them are correct. And it's really hard to choose all of the above when it's the select all that apply question. But remember, this can happen on the NCLEX. Sometimes only one is right. Sometimes all of them are right. So with this, yes, after birth, the risk of clots is higher for 6 to 8 weeks. Yes, they should not go on car rides for more than 4 hours for the first few weeks. If they, for some reason, have to, they must stop their car every hour to get out and walk around for a good 5 to 10 minutes. I always tell people too, when they're traveling, when they're pregnant or postpartum, I say, if you're sitting, I want people around you to think you're antsy. You got ants in your pants. I want you to move your legs. I don't want you to just sit there and let the blood pool at the bottom of your feet. I want you to pump your calves, move your legs to keep that blood pumping. All right. After delivery, we should get up and walk as soon as we are able to prevent clots from forming. Absolutely. They do not want to stay in bed. They're going to get clots. And finally, don't cross your legs. Prolonged, frequent crossing of the legs actually does help clots form. So we want to tell them to avoid that.
Excellent job, Archer nurses. That concludes your labor and delivery lecture with Elizabeth. Again, she is an excellent women's health nurse practitioner who we are very lucky to have here to support you with any of your maternity and labor and delivery questions. So if that's an area of the NCLEX that you're struggling with, if after this lecture you're still feeling a little bit lost, we've got her contact information and her booking page right here